to this teleconference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Hudspeth. I'm the radio program manager for MS Focus Radio, and I'm joined by Dr. Ben Thrower, speaking with us today about B-cell therapies for MS. After the presentation, we'll open it up to your questions and comments. Dr. Ben Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, Georgia. He previously served as a medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for the Multiple Sclerosis Foundation and enjoys contributing to our quarterly MS Focus magazine. Now, when Dr. Thrower isn't dressing up to play the pirate Jack Sparrow, he can be found playing with his new grandson, whose name is Sam. We're pleased to have him join us today. I'm going to unmute you if I can find you. Dr. Thrower, you were just here, and I can... Where did you go? Are you able to unmute yourself?
I think I'm unmuted now.
There you are. There we go. All right. It's been a long time. Good to see you.
Good to see you.
All right.
Thank you to all of the staff at MS Focus for all you guys do. I know it's been challenging through this COVID pandemic. Your work lives have all been turned upside down to a certain degree, but you don't show it. You're carrying on, and we really appreciate everything that all of the MS Focus staff does. And so thank you to all of our listeners for joining in with us. So we're going to talk this afternoon a little bit about B-cell therapies. You know, and some of our topics that we go over, you know, I can show, you know, videos and pictures of individuals, and they're a little lighter. We're going to have to buckle up our immunology seatbelts this afternoon, because sometimes immunology can seem a little bit daunting, but on the other hand, it is so incredibly important in multiple sclerosis and really in our health in general. One of the things that I tell our medical students as they rotate through is, you know, you can maybe doze off a little bit during some of your courses. Don't doze off during immunology. It is so important to almost everything that we do in healthcare. So let's skip on to the next slide, Chris. So as we know, MS is an autoimmune disease. So understanding immunology is incredibly important as it relates to multiple sclerosis. One of the misconceptions that we still hear amongst the MS community is that MS is due to an underactive immune system, when in fact, MS is really due to a relatively overactive immune system. It's an immune system that is attacking myelin and axons in the central nervous system, in the brain and spinal cord. So MS is not due to an underactive immune system. And next slide. So B cells and T cells. So these are two of the major parts of the adaptive immune system. So humans have two major components of our immune system. We have something called the adaptive immune system and the innate immune system. The innate immune system is what we're born with. We have it from day one. Almost all animals have an innate immune system. It's ready to protect us without having to learn anything. The adaptive immune system does just that. It adapts, it learns things. So when you think about exposures to a virus or a bacteria or a vaccination, these are all possible due to the adaptive immune system. Your immune system sees something, it says, you know what, that's not good for me, whether it's a virus or bacteria, and I'm going to kill that something whenever I see it. And so it has memory. It has the memory to attack this offending agent, whether it's a virus or a bacteria, or maybe a precancerous cell as well. And when we think of the adaptive immune system, the two major parts of that immune system are the B cells and the T cells. So B cells are mainly part of what we call the humoral immune system. Humors are things that circulate, so they're chemical messengers that circulate throughout the body, whereas T cells are thought to be more of the cellular immune system. And the next slide. So you don't have to read all of this. I'll summarize it for you. So B cells really do have two major jobs in the immune system. One of the most important things that B cells do is when they grow up, they become a cell called a plasma cell, and they make antibodies. And so antibodies are very important in helping with coordinate immune responses, again, to things like bacteria and viruses. What the other function of B cells is, they also help coordinate what T cells do. And we'll come back to that thought in just a second. Next slide. So T cells, again, are really part of that cellular immune system. And so what they're doing is they are directly attacking things, and whether it's a bacteria, a virus, or they might produce something called cytokines that call in other cells called macrophages that may also help attack things and chew them up. And there are a lot of different varieties of T cells in the immune system, but those are the two big parts of the adaptive immune system. B cells, which make antibodies, are part of the humoral immune system, and T cells, which are part of the cellular immune system. So we mentioned that B cells make antibodies, but one of the other major things that B cells do is, you've got your T cell on the left here and your B cell on the right. B cells and T cells dance with each other. One of the common themes of the human immune system is that nothing exists in isolation. Everything in the immune system coordinates with something else. So one of the major roles of B cells is they present antigens to T cells. So let's say that you have a virus that you've been exposed to. One of the things the B cell may do is it may engulf, sort of take in part of that virus and then present it back to a T cell on the surface of the B cell and say, here, T cell, here's something I want you to react to in the future. So it helps coordinate these cellular immune responses. Next slide. So for decades and decades and decades, we thought of MS as just being a T cell disease. So what I learned in medical school is that multiple sclerosis is an autoimmune disease largely driven by T cells. So here you see on the left-hand side, you've got a healthy axon with the myelin is sort of spread out, and then the little gaps in myelin where the electrical information is going to jump from gap to gap to gap. Now on the right-hand side, we have these T cells. They're inflammatory. They're coming in, and they're either directly chewing up that myelin, or they're secreting these things called cytokines that may help coordinate an attack on that myelin. And from really 1998 on, we know that MS does more than that. It's more than just the attack on the myelin. It's also an attack on that axon or nerve fiber underneath that myelin. Well, as we said, nothing in the immune system is simple. And so while we were a little smug in our thought for a long time that MS was just a T cell driven disease, in reality, we'll go to the next slide. MS is more this. It is incredibly complex. And so every year we learn more and more about the immune system in multiple sclerosis. And what we've learned is, as part of this complex diagram, is that B cells also play a very big role in multiple sclerosis. Some work that was done at Mayo Clinic years ago, Dr. Lucanetti and her team were actually doing either biopsies or autopsies of MS lesions. And what they found is that some people had MS that was largely driven by T cells. Some people had MS that was more driven by B cells. And then some people had this combination of both B cell and T cell contributions. Unfortunately, we don't have a blood test right now that would let us know where a given individual is at. Are you more of a T cell driven MS person, or are you more of a B cell driven, or a little of each? Hopefully we will have that capability someday, but it may explain why some people do better with one therapy versus another therapy in multiple sclerosis. And next slide. So what are the B cell therapies that we have in multiple sclerosis? Well, the original B cell therapy that we had was rituximab, or Rituxan. And so the story with Rituxan is that it was a drug that was designed to treat certain types of lymphomas. And these lymphomas were lymphomas that were largely made up of B cells. And so researchers started thinking, well, rather than just using a chemotherapy and killing the cancer cells and maybe killing a lot of other cells in the process. What if we could come up with a very focused antibody that would bind to a receptor on the surface of that lymphoma B cell and just target that cell and only that cell for elimination? So that's what they did. They came up with a B cell therapy that was very targeted at certain types of lymphomas. Well, once other people in the healthcare field saw this, they said, you know what? Those B cells also play a role in other health conditions. They play a big role in autoimmune disease, multiple sclerosis, rheumatoid arthritis, lupus. What if we could use this very selective B cell therapy to treat autoimmune conditions? So the thought of using Rituxan or rituximab for B cell therapies, it goes back quite a ways. So we were part of research probably 12 years ago looking at Rituxan, and it works very well. Rituxan never got FDA approval for treating multiple sclerosis, and that was in part because the Genentech, the manufacturer, said, we think we can build a better mousetrap. We think we can come up with something that gives us the benefits of Rituxan, but maybe even does a better job. And that's where ocrelizumab or Ocrevus came in. What you'll notice on a lot of these MAB drugs that you see up there is that you have a UMAB, so ocrelizumab, ofatumumab. But rituximab is interesting. It's got an XI in front of the MAB. So your MAB at the end of the generic name stands for monoclonal antibody. If you have a U in front of it, it means that it's a humanized monoclonal antibody. It looks very close to what we have in our body naturally as an antibody. Rituximab was one of the only what we call chimeric antibodies. It's mostly human, but also a little bit mouse. And that's what the researchers thought they could do a better job with, was getting rid of that mouse component of the antibody and rituximab and coming up with a fully humanized version. So that's where Ocrevus came in. All the research on rituximab was eventually dropped in MS and everything was switched over to Ocrevus, and that's what eventually got FDA approval. We still use a lot of rituximab. So we acknowledge that on paper, ocrelizumab looks like it would be the better of the two molecules, but in the real world, we've actually been pretty happy with rituximab. There's now a generic on rituximab called Truxima as well, and we're happy with that drug as well. In the real world, if you took one of our folks on Ocrevus and switched them over to Rituxan or Truxima or vice versa, they would probably never know the difference. They're dosed exactly the same way and every 6-month IV therapy. So when we talk about ocrelizumab, we sometimes say ocrelizumab / rituximab because they're so similar in terms of what they do. Now we have ofatumumab or Kesimpta. This is the most recent addition to the toolbox. This is also a B cell therapy. This is a once a month home subcutaneous injection. So all of these drugs work on something called the CD20 receptor. So these are all anti-CD20 monoclonal antibodies. These are all FDA approved, with the exception of the Truxima and the Rituxan, which are used off label, but we do use them. I threw another drug in here, and that's the inebilizumab, because it is possible that we may start hearing about this some in the MS world. So it is also a B cell therapy. It targets a different receptor, though. It targets something called the CD19 receptor. And we'll talk about the subtle differences between a drug that targets CD20 versus CD19. So that drug is FDA approved for neuromyelitis optica, which is a cousin of multiple sclerosis. And next slide. So again, your rituximab and Truxima are given intravenously every 6 months. Because these are not FDA approved for multiple sclerosis, some insurance companies are not going to cover these. So then what we end up doing is going back to the drug manufacturer and asking for financial help for the individual. Because they're not FDA approved and frequently the insurance companies aren't involved, there's an advantage to that for some individuals with MS. We can give these drugs really as frequently as we would like to. So when you give one of these B cell therapies, what you're doing is you're targeting a certain population of B cells for elimination. These molecules, the drugs themselves, only stick around for a couple of weeks, but the immune effect lasts for months. So let's say that someone is on Rituxan or Truxima and they come back and tell us that, at 4 months, I start feeling kind of crummy. And I think my immune effect is wearing off. And we look at their labs, and maybe indeed these B cells that are targeted by these drugs are starting to come back sooner than the 6 months that we would expect. We might actually move that person to an every 4-month infusion. Ocrelizumab or Ocrevus is FDA approved. It's given every 6 months. If you read the product information, it's a little fuzzy, but you can actually do this one every 5 months. Unfortunately, although medically we'd be perfectly fine in some individuals giving Ocrevus more frequently, with most insurance carriers, they're not going to let you do anything more than every 5 months. Some of the insurance carriers will even fight us on that. They're really not going to let us do anything other than every 6 months dosing. And again, our newest addition, the Kesimpta, is our once a month subcutaneous injection at home. And next slide. So this is a little bit busy, but this is basically the life cycle of B cells. And this is where those CD19 and CD20 receptors come into play. So B cells start life as a stem cell. And if you kind of start at the bottom left and then kind of follow your way around, they end up ultimately as a mature plasma cell that's making antibodies. What you'll notice is that how we differentiate where a B cell is at in its life cycle is based upon these receptors on their surface, and that's underneath each of those cells. So depending upon what receptor that cell is expressing on its surface, we can tell how old it is and what its job might be. So as it relates to MS and MS therapies, we're specifically interested in the CD20 and the CD19 receptor. So what you'll see is the CD20 is present all the way through that cell's life cycle, right up until it becomes a plasma cell. So the point at which a B cell starts making antibodies, the CD20 receptor is there and then it goes away. That's important because if you start targeting the plasma cells, then you might actually start decreasing antibody production, and that could lead to a person being immunocompromised. So we like the fact that our drugs, our anti-CD20 monoclonal antibodies, only target the cell up to the point that it becomes the plasma cell. So if you're nerdy like I am and you want to talk to your healthcare team about what labs they're monitoring, you'll probably notice that one of the labs you'll see pop up in your blood work is called a CD19 level. So what they're doing is they're measuring the number of CD19 positive cells. So we do a blood count, we look at your total lymphocyte count, we break that down into B cells and T cells, and the B cells that we're measuring are the CD19 cells. Why are we doing that if these drugs are anti-CD20 medications? Why don't we just measure the CD20 cells? We do the CD19 cells because the commercial blood test for CD19 is easier and cheaper than the CD20 test. So we're doing 19 to tell us what 20 is doing, realizing that they don't perfectly overlap. You'll notice that as this plasma cell matures, the CD19 receptors are sticking around. That's the major distinction between CD20 and CD19. We mentioned that drug used to treat the cousin of MS, neuromyelitis optica, that is an anti-CD19 drug. So that drug is going to affect B cells even into the maturation of the B cell where they become plasma cells. So that drug has the potential to be maybe more effective than the anti-CD20 drugs that we currently use, but it's also going to come with a price tag. It's probably going to lower antibodies, and it's probably going to be associated with a higher risk of infections. So again, that one is one we're not using in MS right now. It could conceivably be used off label. I don't know if that company is planning on doing any studies for that drug in MS. It would make perfect sense. We would just have to realize that there's a risk benefit ratio when you move to a CD19 drug versus a CD20 drug. Next slide. So how do these drugs work? So if you had asked us I would say 15 years ago, when we first started researching rituximab in multiple sclerosis, we would have said, well, these are drugs that target B cells. B cells grow up to produce antibody. Therefore, these drugs must work on antibody production. And interestingly, that's not what they do. There was some thought that maybe they could lower T cell subsets indirectly, CD4 and CD8 cells. That's not what they do. Those are both good things. We're glad that these drugs don't, in general, lower antibody levels or affect T cell subsets, because if they did, that would make them highly immunosuppressant. And so they might work for MS, but it's also going to come with a lot of risk for infections. What we think these drugs actually do, if you think back to when we talked about what B cells do, B cells make antibodies, but B cells also dance with T cells and present antigen to T cells. We actually think that that's where these anti-CD20 B cell therapies work, is they're preventing or altering the way B cells present antigen to T cells. Next slide. So what are these drugs actually approved for? So Ocrevus is approved for relapsing forms of MS, for active secondary progressive MS, and it is our only drug that's FDA approved for primary progressive MS. Kesimpta, same thing, minus the primary progressive MS. Rituxan and Truxima are off-label for all these things, so not really approved for any form of MS. That term that we use here, active secondary progressive MS, is a relatively new term. I did want to at least explain that a little bit. Next slide. So traditionally, we've talked about relapsing remitting MS, secondary progressive MS, and primary progressive MS. We never really made a distinction of active versus inactive secondary progressive MS. The concept of active secondary progressive MS means someone that we feel that has moved into secondary progressive MS, but they're still having relapses and or new lesions on MRI. That is a very, very fine distinction between relapsing remitting and active secondary progressive MS. I would say a few years ago, the term that was used for these individuals was transitional MS. I think most MS healthcare providers would tend to, in the past, have just called that active secondary progressive MS relapsing remitting MS. And I think this is at least an acknowledgement that not everyone with secondary progressive MS is the same. There are people who are further along into secondary progressive MS who really don't have relapses. They don't have new lesions on MRI. That's not to say they're not getting worse. They may still have progression of disability, but it's not manifesting as new MRI lesions or active relapses. And then there are people who are just in that transition period from relapsing remitting to secondary progressive who still have an active inflammatory component. Next slide. So what are some of the risks of B cell therapies? So if we do start affecting antibody levels, if we do start affecting T cell subsets, we do have a higher risk of infections, especially upper respiratory infections. In the real world, our experience has been if we're doing our job appropriately on our side, we really can keep that to a minimum. When Ocrevus first got FDA approval, and if you look at the package insert, the product information, there's a mention of cancer risk. And the reason that was put in there is that in the phase 3 study of Ocrevus versus Rebif, there were 6 women in the Ocrevus arm who developed breast cancer. None in the Rebif arm developed breast cancer. But when you step back and you look at the natural history of cancer, we would have actually predicted 11 women in both arms, both the Ocrevus and the Rebif arm, to have developed breast cancer. So that 6 was actually lower than what we would see out in the real world. The really odd number that we cannot explain is the 0 in the Rebif arm. There's been a lot of effort and put into monitoring for any cancer signals out in the real world once Ocrevus got approval, and we have not seen anything. When we go back and we look at rituximab, the sister medicine to Ocrevus, which has the same mechanism of action, we have not seen any cancer signals there with that drug. So PML, progressive multifocal leukoencephalopathy, there have been a small handful of cases with these types of medications, but they are primarily what we call carryover cases. So these are felt to be cases that were really not necessarily due to the B cell therapy. They were mainly linked to the therapy that was used before the B cell therapy. So if we, for instance, look at Tysabri or natalizumab, if we stop Tysabri in an individual who is felt to have risk of PML due to high JC virus antibody titers, that risk of PML doesn't go away until the person's been off of Tysabri for about 6 months. And so if I come in and now start one of these B cell therapies in that 6-month window, and that person unfortunately develops PML, the way the FDA rules sort of work is we have to count that as a B cell therapy and a Tysabri therapy case. So it gets, both drugs get tagged, when in fact we really feel like it was the Tysabri that was the offending agent. We see the same thing with the S1P, the Gilenya type medications. There have been a handful of cases with people stopping one of those drugs and going on to a B cell therapy. To my knowledge, there's only been one case in the world of an individual developing PML with a B cell therapy all by itself. It was an older gentleman who was put on Ocrevus, I believe, for primary progressive MS, and he had a pre-existing lymphocytopenia. He had a low lymphocyte count, unrelated to his MS, unrelated to any therapies. So he was mildly immunocompromised before he started the drug. And so that combination of the B cell therapy and being immunocompromised, unfortunately, put that gentleman at risk for PML. Infusion reactions would probably be the most common side effect that we see. In general, people are most likely to have an infusion reaction. So itching, maybe sore throat. Occasionally they can be more severe. They're most likely to have that with their very first infusion. We use a pre-medication cocktail with B cell therapies. It's a little bit of Tylenol, a little bit of Benadryl, a little bit of Pepsid, a little bit of steroids, and some Zofran. And with that cocktail, we know that most individuals are going to do fine with their infusion. In December of 2020, the FDA did approve a faster infusion schedule for Ocrevus. It takes about 2 hours off of the infusion time, but that really is dependent upon how well the individual does with Ocrevus. If the person's had no difficulty tolerating their Ocrevus, maybe that person we can go a little faster and cut 2 hours off of their time with us. If they've had issues where they do feel a little scratchy in their throat or itchy, with skin reactions, that's probably not the person we want to try to speed things up in. And next slide. So we do lab monitoring. So there are laboratory studies that we want to do before we start one of these medications that would include just complete blood count, the T and B cell subsets, but importantly screening for both hepatitis B and tuberculosis. People that have any active hepatitis B, that's a contraindication. And if you've got latent tuberculosis, that's probably not someone that we would want to put on this medication. Our protocol, we also add a lot of these B and T cell subsets, and we also do antibody levels, IgG levels. My feeling is if we stay on top of all of this, we can make sure that the person's not immunocompromised. If the CD4 and CD8, those are your T cells, if those were to drop, or if your antibody levels, your IgG levels were to drop, that's an indication that we're probably pushing too hard. And in that individual, we're going to lower the dose and let those levels pop back up so that they're not at risk for infections. We think that those levels are predictive of your infection risk. Next slide. So we're all living through the COVID pandemic, and so we need to think about, how does that interact with multiple sclerosis and multiple sclerosis therapies. There have been some studies out of Europe that have suggested that people on B cell therapies might have a higher risk of hospitalization or more serious courses of COVID if they do get infected. We've not seen that personally here at Shepherd Center. We have about 450 individuals on one of these B cell therapies, and we've not seen that. This is just my personal feeling. I feel like because we're staying on top of the IgG levels, the CD4 and the CD8 counts, we're not letting people get seriously immunocompromised. I'm not certain that everywhere in the world does that. And so there may be centers out there that are not checking those things. And so you will have a small subset of individuals on B cell therapies who do have low T cell subsets or low IgG levels. And if you're not monitoring them, you don't know that person's at risk. And so that may be the group where we're seeing these things. Next slide. One of the other questions that has come up is with our COVID vaccinations. So we right now have the Moderna and the Pfizer vaccines. It's probable that we'll get a Johnson & Johnson vaccine out soon. And how do we time these vaccines? The National MS Society in January of this year did come out with a statement saying that we feel like the vaccines are safe for people with MS. And in general, we would recommend that people with MS get a COVID vaccine. There may be unique individual situations where maybe someone's had severe side effects with a prior vaccination that we may need to treat that situation separately. But in general, we do recommend that people with MS get vaccinated. There's been a question about the timing of the vaccine with B cell therapies. And the National MS Society has some statements on their website saying maybe we want to think about getting right in between our B cell therapy doses. So for instance, with an Ocrevus, maybe we do it at 3 months in between. It's a tough question. And I think there are a lot of variables there. In all honesty, when we look at someone's immune system once they're established on a B cell therapy, if I do your CD19, your CD4, your CD8, and your IgG levels an hour before your infusion, if I were to repeat those labs a day later, a week later, 3 months later, they really look the same. So people who are established on one of these therapies, their immune function really doesn't fluctuate that much. So in my mind, I'm not sure it matters drastically when we do that vaccine in established patients. And what I don't want to see happen is I don't want someone to miss an opportunity to get vaccinated if they want to. So let's say that we did your Ocrevus dose today, and 2 weeks from now you're offered COVID vaccination. Maybe or maybe not, that vaccine may not be available in 3 months. We just don't know. Hopefully they're going to become more available, but it's a very fluid situation. I would recommend that person go ahead and get vaccinated when it's available to them. The exception to that rule would be in a person who is not established on a B cell therapy. They're just starting it. So if you're just starting one of these drugs, Ocrevus, Rituxan, Kesimpta, in that setting, I would recommend you get vaccinated and have your vaccines finished 6 weeks prior to starting that B cell therapy. The concern is this isn't a safety concern. So we're not worried that your B cell therapy is going to interact with the vaccine and cause some side effect. What we're concerned about is that the B cell therapy could make the vaccine a little bit less effective by affecting antibody production. And so we want you to get as much benefit as possible from whatever vaccine you're taking. So that's why this discussion is occurring. So again, if you're starting one of these therapies, I would try to complete your vaccination series, regardless of what it is, 6 weeks prior to starting therapy. If you're already established on one of these drugs, again, I'm not so sure that we have hard science to say that it's got to be exactly in between doses. I think that may be it, and we'll get to kind of throw it open. For any of you who aren't local, that picture was Lake Lanier in North Georgia. It's our most busy, crowded lake in Georgia, but it can also be quite beautiful. Beautiful sunset. So Chris, we'll throw it open to some questions.
Okay, let me do one thing here. I need to end the slideshow so I can get out.
Awesome.
Here we have a couple of questions already in the queue here. But if you do have a question or a comment, make sure you use the raise your hand feature in the app, or you can send your question via chat. To raise your hand, just click the screen to pull up the menu, select more, it's the icon with the 3 dots, and then click raise your hand. I'll unmute you, then a button will appear on your screen asking if you want me, if you will allow me to do that, and just select allow. So we do have a question from Julio. He says, I'm going to spell it, KESIMPTA.
Kesimpta.
Okay. How do you pronounce that?
Kesimpta.
Okay. Can I take the COVID-19 vaccine, or anything special timing involved? And you just covered some of this, so.
Yeah, so I think Kesimpta is probably the easiest one of the group, because so it's a monthly injection. So really, I mean, you could say, well, at best, if I was going to try to time it in between my Kesimpta doses, I would do it 2 weeks after my Kesimpta dose, which if you want to be really a stickler, and that I would say 2 weeks after your Kesimpta dose. In reality, do I think it matters that much? Could you do your vaccination a day after your Kesimpta dose? Probably. Again, what I don't want people to do is to drastically alter what they're doing for their MS. So you don't want to skip a Kesimpta dose for the vaccine. On the other hand, I don't want you to miss an opportunity to get the vaccine by trying to play with your Kesimpta dosing. So I think at the end of the day, if you had to have your vaccine, a week after your Kesimpta, I think that's absolutely fine. And so there are no safety concerns about Kesimpta and the vaccine. Again, Kesimpta is also, it's an anti-CD20 monoclonal antibody, just like Ocrevus and Rituxan. It's just given as a subcutaneous injection once a month, rather than the 6-month regimen with our other drugs.
All right, we have one more question that came in before. It's from Jimmy. What is the difference between taking vitamin B complex and medicine that destroys the cells?
And that's a pretty big difference. I mean, so when you talk about medicines that destroy cells, so technically our B cell therapies that we're talking about today do deplete one very specific line of B cells. So they are killing a very specific line of B cells. That's in contrast to, say, chemotherapies, where you're killing really any cell that's rapidly dividing. When you think about the good and the bad of chemotherapies, well, the good is you're trying to treat a cancer, a rapidly growing cell. Well, the bad is sometimes those chemotherapies are not very specific. They're not just killing that cancerous cell. They're killing hair follicles, and make your hair fall out. They're killing a lot of other cells that you would like to not damage. So whereas a B complex, you're really not killing a cell with a B complex. I think the hard question is, does everyone with MS need to be on a B complex? Probably not. Is it going to hurt you? Probably not. We do know there's a little higher rate of B with multiple sclerosis. At the end of the day, if you're curious about those things, you can always check the blood levels on B12 or B6 and see, maybe try to hone in a little bit on do you really need these things?
All right. That was my phone. I don't know if that was my phone coming. I don't know what happened here. It's attached to the computer somehow. So all right. So that's going to voicemail. Okay. So let's see. Susan Nicholson, you have your hand up. So I'm going to unmute you and go ahead with your question.
I have primary progressive, and I'm curious about the Kesimpta and why it wouldn't be approved for primary progressive and only the relapsing remitting and active secondary.
Yeah. So it's purely a matter of what they studied. So if we think that Ocrevus works for primary progressive MS, is it likely that Kesimpta would work for primary? Yes. So what it really comes down to is what did they study it for? So drug company can only put in their label what they actually studied and what the FDA gave them an indication for. Unfortunately, so you and I can have a discussion about those gray areas and say, well, logically, we think if X works, then Y should work because they have the same mechanism of action. An insurance carrier may not care much about that conversation. They may say, no, it's not indicated for this. What's frustrating for for us on our end and you on your end is sometimes just doesn't seem to make any sense. We may look at these two drugs, Ocrevus and Kesimpta, and say, well, gosh, they're both god awful expensive. Why would the insurance company care? It's not one's not any more than the other. What you and I are usually not privy to is there may be sort of special deals and rebates and preferred pricing that's going on behind the scenes that we're just not aware of. So even though the average retail price of two drugs may look similar, an insurance company may be getting a better deal on one, and that may be why they prefer one versus the other. But no, medically, yeah, I can't. I imagine they might think about doing a study for Kesimpta and primary progressive MS. It wouldn't surprise me at all if it works just like Ocrevus does.
Okay, thank you for that. Let's see. From the chat, we have Kay who asked, are B cell therapies recommended for MS patients with progression that have treatment-induced secondary acquired immunodeficiency?
So it depends on what the immunodeficiency is. So if someone's progressing, we would like to stop that. And so I would take a step back and say, well, what do we want with any of our therapies? B cell therapy, natalizumab, S1P receptors. We're shooting for something called NEDA, NEDA, no evidence of disease activity. If you have NEDA, you're getting an A+ on your MS exam. So that means you have no relapse, no progression of disability, and no new MRI lesions. So if you're not getting an A+ on your exam, meaning you're not achieving NEDA, then that's where we start thinking about different therapies. If the person has for some reason had their immune system altered by a prior therapy, then we need to start having discussions about what's the risk of putting you on one therapy. So, for instance, we see some people with some of our oral drugs that have a very prolonged lymphocytopenia. Their lymphocyte counts will stay low for months and months and months. You probably would be a little nervous about putting that individual on something like a B cell therapy, because if you've had one therapy that came in and hit your T cells and you're having a prolonged negative effect, so those T cells are staying suppressed for a long time, is it safe to now come in and suppress your B cells? Because now you're hitting both parts of your immune system. Are you going to put that person at a higher risk for infections by doing that? So I think you'd really have to know the specifics of her situation to give her some guidance.
Okay, our next question is from Elizabeth. I'm going to ask her to unmute and she can ask her question. Go ahead, Elizabeth.
This was the first I had heard about MS being either B cell or T cell driven, and I was just curious, can somebody with one driver transition to the other? In other words, if you're B cell driven, can you become T cell driven, and vice versa?
Yeah, that's a great question. I don't know that we know the absolute answer to that, because in the Mayo Clinic studies, it was sort of a one-time deal, one-time biopsy where they went in and looked to see where they were at a point in time. My suspicion would be no, that how your immune system is driven is probably largely genetically determined. And so, if you tend to be more of a B cell reactor or a T cell reactor or a mixed, it's probably not going to alter. Then that's not to say the immune profile doesn't change in people with MS over time, but I don't think it's a change in the cells that are driving it. There is this concept of something called epitope spread that happens in MS over years. So the epitope is the site in your central nervous system that your immune system is attacking. So maybe a certain myelin protein is being attacked, and over time, your immune system spreads out and starts attacking more epitopes. That's one of the driving reasons behind getting people on therapy early with MS. It's a lot easier to put that fire out when that epitope is fairly limited. It's only attacking this versus when it's attacking this. So you've got a campfire that's out of control versus a forest fire that's out of control.
Okay, we have a good number of questions remaining here in the chat. Is the only difference between Ocrevus and Rituxan the human mice component? It's from Julie.
Yeah, that's basically true. So one is a humanized monoclonal antibody, and the other one is chimeric. In terms of what they target, they both target the CD20 receptor. They're both every 6 month IV therapy. So again, that really is the major difference, is that molecular difference.
All right. Next question's from Judy. Are you seeing more people being refused for infusion therapy if they've been on earlier modifiers and haven't been on oral agents?
So it varies a lot from insurance company to insurance company. So what she's talking about is this thing called step edits. So the insurance company says you have to try A and B before you get to C, and it varies quite a bit from insurance company to company. What a lot of MS centers in the U.S. and Canada are pushing for is the concept of being as aggressive as we can be as early as possible. So rather than working through maybe two drugs that are not very effective before you get to a third one that is more effective, why don't we just use the more effective drug right up front if we can do it safely? And so I think that's where the medical community is pushing back on the insurance companies and say, listen, we're not so sure we want to work through all of these medications. If we're forced to use less effective therapies, and show that the person doesn't respond completely to those before we get to a more effective therapy, there is the chance that person with MS has now accumulated permanent disability that with our current technology, that we don't get a do-over on. So it is frustrating because those step edits also can change from year to year. So the hoops that an insurance company wants you to jump through this year can be completely different than next year. But I would say in general, we've won more fights than we've lost with insurance companies if we can get one-on-one with a peer and explain to them this is why we're pursuing this course, and we don't want to have to work through all those different medications.
Okay. From Karen, certain age you like to take people off Ocrevus.
So this is a tough one also. So we know that as humans get older, that our immune systems mellow out a little bit. So that's called immune senescence. So our immune systems calm down. So it's a lot less likely to see a 70-year-old with angry inflammatory MS than it would be to see a 25-year-old. So most people with MS at some point in their life can probably come off of their treatment. The problem that we have is that age varies a lot. And that's not just Ocrevus. Most people with MS could probably come off of treatment at some point in their life. Maybe at that point, we just leave them on vitamin D, and that's enough protection. The problem is we don't have a blood test that lets us know when the person's hit that point. So it's a guess right now. And what we don't want to see is someone else making that decision for you. It's a discussion that should really occur between the healthcare provider and the person with MS and their support team to say, what are the factors here? How much of a hassle is the medication? Are there side effects from the medication? Is it a financial burden for you? Are you really getting hit hard financially? Is there anything we can do to fix that? And then what's the benefit of staying on the medication? If at the end of the day we decide, you know what, you're 70 years old, you've been on Ocrevus or Copaxone or Tysabri or whatever drug you want to pick, and you've been stable for the past 20 years, maybe you could do okay without this medication. Maybe we stop the drug at that point. I like to bring that person back at about 6 months and repeat an MRI to make sure that we're not seeing anything blossom under the surface to suggest that we're not going to get away with this. And so I think that's where that question comes from. Is it is a discussion, but it's a discussion with a lot of moving parts.
Okay, our next question is from Lydia. Does Ocrevus just help to prevent new lesions, or does it also help with decreasing progression of disability?
So ideally, it does both of those things. So again, in the primary progressive trials, it was primarily studied to stop progression because relapses really aren't a part of primary progressive MS. In the relapsing remitting trials, it was shown to help prevent new lesions, help prevent relapses, and prevent progression. So, really, I hold all of our therapies to the same standard. there are subtle differences in the way trials and drug trials are designed, and maybe a study really wasn't designed to look at progression, but I would hold Ocrevus to the same standard that I would hold Rebif, Copaxone, Gilenya, any of the drugs. We're shooting for an A+ on your MS exam, regardless of what therapy you're on. And again, A+ is no progression, no relapse, no new lesions on MRI. And if we're not getting that, then we're going to start having a discussion about, is there something else out there that could potentially give us that better response?
Okay, let's go to Karen, who has a question. And Karen has her hand raised, so I will ask her to unmute. Hello. Hi, Karen.
My question is somewhat related to the COVID vaccine. The mRNA technology, BioNTech in January stated that they may be coming up with an MS vaccine. I emailed them and they got back to me through their patient portal to say that they're 2 to 3 years away from actual clinical trials. What are your opinions about how hopeful you are?
I'm hopeful. So when you think about where we're at with monoclonal antibodies, so once people figured out monoclonal antibodies, you saw this explosion of things for MS, for rheumatoid arthritis, for cancers. This messenger RNA technology could be that same next big deal. So because when you think about what messenger RNA is, it's a blueprint for a protein. So you're giving your body a blueprint for a protein, and you're telling your body, okay, make this. Well, what about, say, a kid with Duchenne's muscular dystrophy? If they're not making a certain protein, can we now give them messenger RNA and say, okay, your body can't make it or doesn't have the genetics to do that? We'll bypass that. So the idea with the messenger RNA for vaccine for MS is a little bit interesting because it's a vaccine, but it's actually a vaccine that would teach immune tolerance. So normally when you think about vaccinating yourself, you're vaccinating to get a bigger immune response to something. Here you're vaccinating the person with MS, telling their body to make a myelin protein in small amounts to sort of teach your body to tolerate that protein. It's kind of analogous to doing an allergy shot. You're exposing yourself to low levels of something that your immune system wants to react to and teaching it to not react. So they've done the animal models. So they've done the EAE, the experimental allergic encephalomyelitis, which is always our starting point. And now we need to just see kind of where do we go from here. So it'll go into a phase 1 human trial. And then, but you're right, that normally is, if you're looking at trials for relapsing or progressive forms of MS, realistically from phase 2 on, those are probably good 2-year studies. So it could end up being a really big deal, but it's probably going to take us a few years to know for sure.
Okay, we have a oops. Did you have one more follow-up?
Nope.
Okay.
No.
Okay, thanks. Okay, sorry about that. So our next question is from Angela. Is there any MS therapy or complementary therapy that can help with overall reduction of inflammation?
So, I mean, I would argue that all of our disease-modifying therapies really are anti-inflammatory. I mean, they have a lot of different pathways and mechanisms of how they do that, but I would say every disease-modifying therapy for MS is ultimately anti-inflammatory. Not anti-inflammatory in the big sense that you could use it to treat, rheumatoid arthritis, but anti-inflammatory specifically as it relates to MS. I think there's been a lot of interest in diets that might be less inflammatory. If we're not putting bad things into our body, a lot of saturated fats, you could argue, would probably be inflammatory. So, moving towards diets that are higher in healthy fats and higher in fruits and vegetables probably is anti-inflammatory. There's a lot of interest in cannabinoids. So the cannabinoid chemicals in cannabis or marijuana, there's a lot of evidence that those may be anti-inflammatory. So, does CBD that's available in all 50 states, is that anti-inflammatory? Maybe. I don't think we've been able to prove it for sure in MS. But interestingly, if you look at all of the big pharma companies, a lot of those big pharma companies have a division that is looking at cannabinoids also for treating different health conditions. Some are focusing on MS, others focusing on other autoimmune conditions. I think you could argue other dietary supplements, things like turmeric. There's some good evidence epidemiologically in humans that it's anti-inflammatory. In the animal model of multiple sclerosis, it looks anti-inflammatory. You could argue that exercise is probably anti-inflammatory. When you look at the chemicals that our body produces during exercise, a lot of those things seem to be anti-inflammatory in nature.
Okay, we have a few minutes left and a few more questions. You might have answered this earlier, but I just want to make sure we're going down the list here properly. Could vitamin B deficiency increase the progression of MS?
So vitamin B deficiency, specifically vitamin B12, you get a white matter disease. You get a myelin disease with B12 deficiency. And so when someone is being evaluated for MS, one of the things we do are B12 levels to make sure that we're not really labeling someone as having MS when really they have B12 deficiency. If you have MS and B12 deficiency, I mean, you've got two issues then that are both picking on myelin. So certainly we want to keep a watch out for B12 deficiency and correct it where we need to, because that's easy to correct if needed. But they are both white matter diseases.
Okay. And a second to that question from Angela, who has a corollary to the question: could an abundance of B12, 4,000%, cause progression or acceleration of relapses?
I know there's been some discussion about is there B12 toxicity. I'm not excessively worried about people having too much B12. Again, I don't want to go nuts with it. So, but if someone has a level that is 110% of where we would expect it to be, so they're just running a little high, I don't think I've ever seen any negative to that. To my knowledge, there's not any data to suggest that mega doses are toxic, but I don't think there's any benefit to doing it. I mean, in theory, our body you would just pee out what B12 you don't need. So the vitamins that where we worry more about toxicity are the fat soluble vitamins. So A, D, E, and K are clearly toxic if you get too much of those. So you can't just randomly megadose with any of those. We know vitamin D deficiency is prevalent in the MS community. About 85% of people with MS are vitamin D deficient, and we want to correct that appropriately. We want to get you up into a 25 hydroxy vitamin D range of between 50 and 80. We don't want you to megadose blindly with vitamin D, because you get too much vitamin D, you get risk of ectopic calcification. You can start depositing calcium in places you don't want it to be, like your coronary arteries. You can actually have a higher risk of cardiovascular disease. You can put it in your kidneys and have a risk of kidney stones, which will ruin your day.
Okay. A couple more questions. Do patients on DMTs respond to therapies differently after 40? And will the age change the effects of the treatment? They're specifically asking about, this is going to be a tricky one, DYMETY.
Dimethylfumaric acid.
Yeah, there you go.
There you go. So that's the generic on Tecfidera.
I just wanted to make sure you know. Yes.
Yeah, there you go. So I don't think humans respond differently immunologically as we age. I think what may happen is as we get older, sometimes we see this every day. Someone comes in and says, I'm on drug X and it's supposed to be very effective. My MRI is stable. I don't have any new lesions and I'm not having relapses, but I feel like I'm getting a little bit worse. I don't think that's the person's immune system becoming resistant to the drug. I think what's more likely to explain that subtle progression as we get older is something called loss of neural reserve. So all of our brains and spinal cords have a little bit of built-in resistance to injury, whether it's MS or stroke or trauma, but we lose some of that reserve as we get older. and we actually start losing it after about age 30. It's a little bit humbling to think about that, but all of our brains start shrinking a little bit after age 30. And so maybe the person who's had MS lesions over time, so think of that MS lesion as like a tree stump under the water. Your neural reserve is the lake level above that tree stump. If you've got enough neural reserve, you're not aware of that tree stump under the water. As we age, the water level starts dropping a little bit, and now that tree stump is above the surface of the water, and now it's a problem. The tree stump didn't change. Your immune system didn't change. What changed is you lost some reserve status. So one of the areas of a lot of research, and I know people are very interested in it, is neural repair. How do we put water back in the lake, or how do we make the tree stump smaller? And I think we are getting closer and closer to that. And I do think we'll have it in our lifetime. I would say it wouldn't surprise me if within the next 5 years we might have something that it is going to be a potential neural repair agent.
Oh, that's great. Awesome. And unfortunately, that's all the time we have for questions, Dr. Thrower. It's sad when these things come to an end, because I appreciate having you on so much.
Thank you, and thank you to all the MS Focus staff, and thanks to all the folks out there for joining in. I hope everyone's staying safe and warm. If you're in the area affected by the freeze, I hope your power and your water are back on as well.
Yeah, absolutely. And thank you for putting all your time and effort into this. I know it's not a B cells and T cells are a little tricky to make to understand. So thank you for making it simple for those of us who need the extra help.
I hope I haven't hurt anyone's brain. I know it's a mouthful to wrap yourself around.
Yeah. So if you missed any part of this conference, we are going to replay it on msfocusradio.org, and it will be available on demand on our MS Focus SoundCloud page, as well as our YouTube channel. You can join us tomorrow at 4 p.m. Eastern for Family Planning with MS with Dr. Sabine Lulu. Again, that's tomorrow on Zoom at 4 p.m. Eastern, 3 Central, 2 Mountain, and 1 Pacific. Make sure you follow MS Focus on Facebook, Twitter, and Instagram for times and access information about tomorrow's Zoom and any of the other Zooms that we have. And finally, remember that National MS Education and Awareness Month begins March 1st. Our theme this year is Are You Okay? Your Feelings Matter. It's full of all kinds of Zoom conversations that'll be happening as well starting next week. And again, finally, thank you again, Dr. Thrower. Any final thoughts you have for us?
No, just thank you everyone for being here, and we look forward to next month.
All right. See you guys again soon. Bye-bye.